Primeiramente, boa noite a todos, agradecer aí pela presença. A nova diretoria, que é composta por mim, pelo Franz, pelo Maurício Lima e pelo Marcos Vinícius, nós montamos um projeto agora que nós vamos trazer todo mês uma inovação de alguma técnica que está chegando no Brasil, e nós convidamos um expert do exterior para dar essa aula e um brasileiro vai moderar, tá? Então, seria uma maneira de fazer com que todas as pessoas, tanto dos grandes centros como dos pequenos centros, tenham acesso a essas novas tecnologias, explicadas por uma pessoa que já tem um know-how para isso, para que nós possamos fazer da melhor maneira, tanto para usar como para indicar. Tá? Hoje nós teremos a aula do professor Adam Lewis, que é sobre os tratamentos da articulação sacroilíaca. O moderador vai ser o Maurício Lima, tá? E eu queria inicialmente agradecer a N, que está patrocinando, e vai mostrar o dispositivo dela, que é o Simpact. Eu queria agradecer o Yusley aí pelo apoio, por trazer o Dr. Adam para dar essa aula para a gente, e espero que todo mundo aprenda. Então, nós vamos iniciar com o vídeo do patrocinador, e em seguida a aula do Dr. Adam Lewis. Thank you, Dr. Adam. Bom, Lima, eu queria que você apresentasse o Dr. Adam Mills e, em seguida, para ele começar com a aula dos tratamentos da articulação sacroiliaca.
Maravilha, vamos iniciar. Dr. Adam, it's such a pleasure to have you with us. This is our first meeting of the new course of our branch of the Brazilian Spine Society, that is São Paulo Spine Society. This is a society composed by neurosurgeons and orthopedic surgeons who have their own focus on spine. And this is the first meeting of this new approach with our course, have the focus in emerging techniques. And we choose the sacroiliac joint fusion and your experience in sacroiliac joints issues to start our course. We know that this is an interesting topic for both orthopedic and neurosurgeons, and also we had very positive feedback about hip surgeons that all are also interested in this topic. And we are very pleased to have you with us and to have the opportunity to share this experience that you have in more than 1,000 cases of sacroiliac joint fusions. And we would like to spend the next hour with you and with such experience in this topic. Thank you so much for accepting our invitation, and thank you so much for your lecture.
Well, thank you for having me. It's a pleasure.
Thank you. So, be our guest. You can start whenever you want.
Okay. Do we have the presentation or the slides?
I think that you can share your presentation with us. You can share your screen.
So, and you see my picture there with the SI joint fixation, correct?
Yes. Okay. I think that now you should try to put in your presentation mode.
Great. You see it now?
Yeah.
What do you see?
I see the United States map.
Yes. And it says, good evening.
Yes.
Welcome from Mississippi. Mississippi is in the southern portion of the United States. very close to New Orleans. It's the home of Elvis Presley from Tupelo, Mississippi. And Oprah Winfrey was born in Mississippi as well, in a small town called Kosciuszko. And I've been practicing in Mississippi since 1996, first as a professor at the University of Mississippi, and I've been teaching neurosurgery since that time, and teaching nationally and internationally. And about 12 years ago, I got interested in the sacroiliac joint because I had a lot of patients who got better after spine surgery, after back surgery and fusions, but then they complained that they were still hurting in their hips. And I had a partner in pain management who did injections, who did rhizotomies, pain pumps, and spinal cord stimulators, but he continued to have problems with his patients still hurting. So what I'd like to talk to you tonight is a little bit about the basic science and the anatomy, talk about the pathology, what causes it, and how often did we see it in our spine practices. And then when we do see it, how do we diagnose it? What is the best way to make the diagnosis? And then when we have tried non-operative treatments, I'm going to go through all the non-operative treatments that you could try for your patients. After that, if they still are struggling, they can't sleep, they can't do their work, they have trouble doing things around the house, like housework or yard work, then that's when we decide to fix it. And we can do this in a minimally invasive option without cutting any muscles. And it's a short operation. And I'll show a little bit of the surgical technique and some case examples. But what I hope to do today is to give you a new kit or new toolbox or a new skill set for your practice. As you can see, it's a forgotten joint or a lost joint between the spine surgeons up above and the hip and knee surgeons down below. It's the largest joint of the body. And a lot of us see it, but we don't really understand how to treat it or how to make the diagnosis, or where do we go from here. And in the past, we've always sent them to pain management in the United States. But even now, the pain management doctors are sending them back to us to stabilize the joint. The most common pathology you're going to see is after spine surgery. If you are doing spine fusion at L4-5 and L5-S1, then you are going to see adjacent segment disease or degeneration. You're going to see degenerative SI joint. And the easiest way to see that is on a CAT scan of the lumbar spine, where you will see vacuum changes of nitrogen gas in the sacroiliac joint. You can also see it after trauma, but this is less common. 80% will be after spinal fusion, trauma after falling off a ladder or after a car wreck, something like that. You can also see it if people harvest bone from the iliac crest posteriorly. Afterwards, they can get into that joint and cause instability of the joint. So, and then you see it in, of course, scoliosis. Degenerative scoliosis will put extra stress on the joint. Rheumatoid arthritis, less common. And then after pregnancy, see that as well. If you look at the prevalence of low back pain, it's there, but often we never looked for it unless we include it in our physical examination. And when you look at the studies dating back to over 40 years ago, 1987, 22% of the patients with low back pain had sacroiliac joint-related problems. And Cohen in 2005 also found about a 25% incidence of SI joint pain in the low back, but it was frequently overlooked. And this was echoed by Schwarzer in 95, Main in 96, and then recently, Jonathan Sombrano and David Pauly found that up to 25% of their patients had significant pain coming from their SI joints when they were referred for spine surgery. Of course, you have to rule out other things like a herniated disc or compressed nerve radiculopathy. And it can look like a compressed nerve at L2-3, L3-4, L4-5. Certainly stenosis, L3-4, L4-5, can mimic an SI joint. And you can get instability, L4-5, grade 1 spondylolisthesis, or even facet joint pain can look like sacroiliitis. Certainly you want to watch out for cancer, which might be manifested as weight loss or night pain, infection with fevers or sweats, or severe trauma that's where there's a big disruption. But the contributing factors to SI joint pain in your practice, if you do degenerative spine disease and treat that, is you're going to see prior lumbar fusions. 75 to 85% of the people you see. So if you're just getting started with treating sacroiliac joint and you want to make sure you're doing the right thing and doing the best job, the majority of your patients, or 4 out of 5 of your patients, will probably have had a prior lumbar fusion. And of course, we talked about these other ones too. They also may have been treated previously with pain management, with prior rhizotomies or prior injections. And that helps point the way toward the sacroiliac joint as the factor in the pain or the pain generator. So when your patient comes into your office, these are the questions you want to ask them. Do you find it difficult to sit for long periods of time with pain? If they're shifting in their seat back and forth, they'll say yes. Do you have to move from side to side when sitting? Do you have trouble sleeping comfortably at nighttime? Do you have pain in your buttocks when climbing stairs? Does your pain worsen when you get in and out of the car? Driving over a bump in the road, does that increase the pain in your back or your buttocks? Do you have difficulty and pain when standing on one leg for a long period of time? Does your leg seem to give away when you take a step? Do you feel pain in your groin area? People with sacroiliac joint pain will say yes or sim to many of these. And that helps when you're explaining it to the patient, because when you check sim every time, they're going to say, that's me. That's my problem. And they can identify with it. Here's the pain diagram. Looks very similar to L5. Starts here at the posterior superior iliac spine. You can have groin pain too, but it's below L4-5. It's right here on the dimples. And again, you're going to see things that look like a hip problem. You're going to see things that look like a radicular pain, but they'll have disturbed sleep patterns. They can't sleep on that side. They'll have trouble sitting. They can't sit on that side for very long. And they'll feel like their leg is giving away when they're walking. So the finger Fortin test, as we talked about, that's pressing right on that dimple. And then there are 6 provocative tests that we do. Yeoman's sign is not included in this one, but that's also one. And if you have 3 out of these 5 tests, they're positive, it gives you a good idea that this is an SI joint problem. And if 1 out of the 3 of the positive tests are positive, either the compression test, cross compression across the hip, or the thigh thrust sign, then you've got an 85% sensitivity and 76% specificity, or specific. The best gold standard is to do an SI joint injection under X-ray. Make sure you're in the SI joint under X-ray. And if they have 70% relief of the pain, 50 to 70% relief of the pain, then you know that's the source. So the injection is not only diagnostic, it's also therapeutic. Again, stepping up, sitting, and sit to stand. That's the Fortin test where we press right there. And if you show them a picture, they'll say, yes, that's me. This is how you bond with your patient. And certainly the diagnostic injection, if you put the dye in at the lowest portion of the joint and the dye runs up in through the joint, you know the joint is incompetent. And that's a source for pain. These are those provocative tests I described. There's the pelvic tilt, not always positive in pelvic tilt, only about 10% are positive. But the thigh thrust is very common, and the Faber, flexion, abduction, external rotation, very common. We put the heel on the shin and open up, and they'll feel pain right over the back on the SI joint. Also, the cross compression. This is a very important one here. Very, very common, usually 80 to 90% positive. So the thigh thrust, very common, 70%. Faber's often 75%. Cross compression, 80%. Gessling only about 15 to 20% positive. And then the yeoman's sign or artificer's sign. You can do additional tests to be sure. See how the patient sits in the chair, tenderness over the pubic symphysis, and trying to stand for a long period of time on one leg. And so now you've made the diagnosis. You've had your injection, and the patient obviously has some SI joint pain. You feel confident about that. Maybe they had a prior fusion at L4-5 or L5-S1. And so now what do you do? Well, I'd like to think of it as 3 legs of a stool. And there are 3 types of medications. You have anti-inflammatory medication, muscle relaxer, and something for nerve pain, like gabapentin, meloxicam for inflammation, things like that. So oral medications are the 3 legs of a stool. And then we have 3 therapies. We have physical therapy, we have chiropractic care, and of course, therapeutic injections. You can also do a pelvic brace or a back brace. I give them SI joint exercises that they have on YouTube, that they can do video exercises. There are 7 basic exercises. And if these things work, great. If they get better with their sleep, they get better with their activities around the house, wonderful. If they are, if they're able to go back to work, then continue doing those non-operative treatments. However, if they are not successful with these options, then I think the next best step is to stabilize or fuse the joint. You could certainly do a rhizotomy as well. There's no harm in doing a rhizotomy, but the rhizotomy has to hit 4 nerves in that joint, and that's difficult to do, and it's not always successful. I think the gold standard when everything else has failed is to stabilize it. And I use this system. I think it's a great system from LifeSpine. I've done probably 300 cases with this system. And it has, as it rotates and turns, it pulls bone from the iliac crest into the screw. So there's a bony interface, and you're pulling those stem cells in from the iliac crest. And it's they have a variety of sizes. The most common one is the 12 millimeter diameter, and it's easy to do. It has it's not a steep learning curve. The hardest part in doing the procedure is putting in the first guide pin, and then there's a parallel pin guide that follows. And very similar to the way furniture fits together with wooden pegs is how I describe it to patients. This stabilization spot welds the joint in 3 locations. You can also do it with 2 if you have a small joint or you don't feel comfortable putting a 3rd screw in place. And this is what it looks like. It's very simple and basic. Here's this lateral view, and you see the 3 pins. The pin, you want to start the first pin below the alar line. And that's because the L5 nerve root runs just rostral to the alar line. And so if you are above the alar line, you potentially could injure the 5th nerve. When you look at the AP view, you could see it goes straight across the joint and very reproducible, very stable. And then there you want to avoid the S1 foramen, which is here across from the 2nd screw. It's a very reproducible, safe procedure, but those are the 2 nerves you have to worry about. You have to worry about the 5th nerve at the top, and that's why we use these landmarks. And I'm going to show you some more of that here in this presentation. And you also use the outlet view. You want to measure the top of the joint as well as the bottom of the joint. And you don't want to get too low on the bottom of the joint because the bone becomes softer and it's harder to stabilize. Also, there is the superior gluteal artery, which runs out of the sciatic notch, and you don't want to injure that superior gluteal artery because it can lead to a pseudoaneurysm. It's a very safe procedure. Again, the biggest risk would be having to revise the implant. If it gets too far forward into the S1 foramen would be the biggest risk, or if it's above the joint itself and you are up against the 5th nerve. Again, removing the implant is straightforward, and you want to do it early on. If the graft is not fusing or shifting out of place, that's uncommon. There's a 94% clinical success rate with this, and at 2 years, it's 90% durable, meaning patients are still happy with the results. But if you have a non-union or it does not fuse, the best approach is to augment the fusion, to add more screws to the fusion rather than remove and replace. Bladder and bowel dysfunction, I've not really seen anything with that. Again, it would have to be out of the normal position of the joint. The need for more surgery would be to augment or to perhaps stabilize posteriorly. And if the pain is not improving, then you have to look at other sources. And presumably we've done that preoperatively by getting an MRI or a CT scan of the lumbar spine and looking for another source of impingement. But again, once you've gone through all these steps of doing the non-operative treatments, making the diagnosis, your success rate is 94%. So I like to get a CAT scan beforehand also. It looks at the anatomy. Occasionally you will see some abnormal anatomy where the joint is wider on one side or the other. You can use any table. We use a Jackson table in America, but a flat table is fine too. Or some kind of spine table is fine. You can also use a vascular table. There's plenty of room underneath to get your inlet and your outlet view. We use chest rolls, very simple positioning, and a little face rest for the patient. And we use one C-arm. And I'll show you those. There are 3 basic views. The first is the lateral view here. And you can see the joint. It's like a boomerang. And the alar line is up above at the top, rostrally, and that's where the 5th nerve runs on top. So we want to start below the alar line. And if you look at the sacral line, you'll see that the joint actually dips below that. So you have extra room in the mid portion of the joint to put another screw there. This is the inlet view. It's the width of the body, and we want to make sure that the screws go through that width of the body of the joint. But you can see it dips down below, and that is a place where you could go down as low as you want there. You can also go more posteriorly, up higher. Here's an X-ray view, and this shows the inlet landmarks. This is the width of the joint. The inlet view, it's 30 degrees into the buttocks as an easy way to remember it. And you want the screw to go through that point. When we first put the pins in, we want all three views to line up, and that gives us feedback as to the best position. Here is the outlet view where we have the S1 foramen and the S2 foramen. Most of the screws revolve around the S1 foramen. So the S1 nerve is the most important one here. You don't want to go into the S1 foramen with your screw. It's okay to go into the S1 foramen with your guide pin. If it goes a little bit too far forward, you can pull it back. If they wake up with a little nerve irritation afterwards, I give them a little Decadron, and I give them a little bit of Neurontin or gabapentin. And it usually resolves in 24 hours. So give them just get reassurances that it's okay. If you're not sure, or in the beginning you want to get a CAT scan to look, I have some people in America, some good friends who do a lot of these, and they at teaching institutions, and they do CAT scans to show the residents, okay, this is where the screw went. So it gives them feedback through that. Certainly, you can also use navigation. I don't use navigation myself because I work in mainly a smaller hospital where they can't afford $1 million robot. But certainly, you know, it can be done with navigation, and some people, the younger guys, like that. But you don't have to have navigation for that. Here's that outlet view again, and it's usually 30 degrees opposite, or 90 degrees opposite the inlet, so it's 30 degrees down the butt. And so 30 degrees inlet and 30 degrees down the butt. And what you'll see are the S1 foramen and the S2 foramen. And you see the S2 foramen is at the bottom of the joint. It really doesn't come into play very much. The first screw is usually above the S1 foramen. The second screw is toward the S1 foramen. And the third screw is inferior or caudal to the S1 foramen. The lengths of the screws are very consistent, usually about a 50 millimeter screw above the S1 foramen, that's the superior, a 45 millimeter screw in the middle, and a 40 millimeter screw inferiorly. Here are the X-ray views that you see. Again, just to repeat and summarize, the lateral view with the alar line is important, and then the sacral line, and then inferiorly you have the inlet view, which is 30 degrees into the butt, which shows the width of the joint, and then the outlet view, which shows us the superior portion of the joint, the inferior portion of the joint, the S1 and the S2 foramen. And so here's how we do it. The first guide pin is placed below the alar line in the lateral view. And then we move to the inlet view, 30 degrees into the butt. And this shows the guide pin going through the middle of the bandwidth of the joint. And then the outlet view, which shows going up to the joint and then across, working the first guide pin is below the top of the joint, but above the S1 foramen. So here's an example, a 49-year-old woman, and this is a patient of mine with SI joint pain on the right side. She has tenderness to palpation over the right sacroiliac joint, and the provocative maneuvers elicit pain in the joint on examination. There's degeneration and vacuum changes of both sacroiliac joints. You can see that here with the black or the nitrogen gas, air in the joint bilaterally. This is not the worst case, but it's a good example of where you'll see that. She failed to improve with physical therapy. She underwent multiple positive injections of the SI joint. It's not uncommon if you do a diagnostic injection to come back during therapy and do a confirmatory injection. That's always helpful. You confirm the diagnosis, and that makes you feel better and it makes the patient feel better. And when she had failed to improve with physical therapy and injections, we brought her to the operating room to undergo a right sacroiliac joint injection. And here's the example of the views. You can see in the bottom left, these are the 3 guide pins that we put in. And you can see the top guide pin, the middle guide pin, and the inferior guide pin. The top guide pin is below the alar line. The inferior portion of the joint is down below, and we want to stay away from the most inferior portion of the joint because it becomes more narrow. The superior gluteal artery is in that area, and the bone is softer. And this is an ideal candidate. She's had a previous fusion at L4-5, an anterior lumbar antibody fusion, and she's developed adjacent segment disease in the SI joint. So that's the lateral view. And then you see up above in the upper left is the inlet view. And you can see the screws almost all line up together in a single line. They're right in the center of the joint, the top of the joint, and the inferior portion of the joint. And then in the upper right, at 1 o'clock, and you see the 3 screws going through, and you see the S1 foramen, and you see the S2 foramen. And the screws are basically equidistant across the joint. So there's 25 millimeters lateral to the joint, and there's 25 millimeters medial to the joint on the first implant. Same thing, the level below it. There's a stair step of about 5 millimeters, and it's about 22 millimeters on the lateral part, 22 millimeters on the medial part. And then finally at the bottom, 20 millimeters lateral, 20 millimeters medial. And then the final is the bottom right at between 4 and 5 o'clock. And you see the 3 screws across the joint, inferior to the alar line, and in the center portion of the joint. And there's a gap in between where there's bone to grow through. Here's a CAT scan at 6 months, and you can see a inlet view showing the screws growing across the joint, and a axial view, and you can see the gray where the bone has grown through that. And the patient had excellent relief with her back pain. You don't have to get a CAT scan at 6 months, but we just do that as a routine. And we also do Oswestry Disability Index, and we do visual analog scale and an SF-36 or functional scale. But I just do that in my own practice, so it gives me feedback about how well we're doing and what kind of results we're getting, so we can make adjustments if necessary. Here's another view, very simple. Again, the screws don't have to be in exact order. They could be in alignment like this. They could also be triangulated. Here's a good example. And again, a fusion at the top. And after about 5 years, you'll see many people will develop SI joint dysfunction. This is the inlet view across the joint. You can see it clearly above the most inferior portion of the joint, but also inferior to the most superior portion of the joint. Also, you can see the screws on the outlet view. They don't have to be exactly straight. You can be convergent, you can be divergent, and you can be straight. There's no clinical decision making that one's better than the other. I tend to favor the inferior third of the joint for putting in the screws because the bone is more dense. But again, no one has shown clinically that you're better served being at the inferior portion or the middle portion or the superior portion of the joint. Here's a good example. The joint is quite wide. You can actually put other screws. You could put up to 6 screws in here if you wanted to. And just a good example also of patients who've had long construct fusions will often develop SI joint dysfunction. And so many deformity surgeons will fuse the SI joint when they do their long construct realignments of scoliosis. You can also use a triangle. You don't have to go lengthways. If your joint is short, or if you don't feel comfortable going inferiorly, you can triangulate and get excellent results. Again, staying below the alar line. And that's it. Yeah.
Thank you so much, Dr. Adam, for an interesting lecture. And we have some doubts that we would like to ask you.
Sure.
I will split the questions so I can make the question and you answer, and then we go like this.
Yes.
First of all, you talked that you always use injections to diagnosis and treatment. And what is the result expected? And to consider diffusion, does the patient has to have an excellent result or a moderate result after the injection? And when you think about fusion?
Yes, well, certainly you want a good result on your injection. You want to make sure you're in the joint, for example, that you do it under X-ray or under fluoroscope or CT guided to make sure that you're in the joint, outline the joint. And if they get 50 to 75% relief, then you have a good idea that that's where the problem lies. If you have a normal MRI or normal CT scan of the lumbar spine, and you do an injection of the SI joint and they get excellent relief, it's a pretty good idea that that's where the problem lies. But if you're just starting out and you're not sure, again, the provocative maneuvers are important. A prior fusion at L4-5 or L5-S1 is important because that will point you in that direction. And then a simple CAT scan that shows vacuum changes will also point you in that direction.
Great. Great. Perfect.
And of course, you know, the best results or the best way to know if you made the right diagnosis is if they get better afterward, right? If they get better, you know, you hit the home run, or, you know, you scored a goal.
Perfect. And how long do you wait after the injection, after the infiltration, to think about the fusion?
Well, I do the first injection. If they get better, great. Then they don't need you anymore. But if the pain comes back, I'll often tell them, let's do a confirmatory injection. Let's do a second injection and see if you get the same kind of results. Again, if you get 50 to 75% relief, then you know, yes, this is the source of the pain. It wasn't just a lucky shot the first time.
And rhizotomy is not a tool in your practice.
No, I'm not saying that. I'm saying we do rhizotomies in our practice. And certainly in America, most of the pain management doctors will try a rhizotomy. But I've found in my practice, and I think this is echoed by other experts in the sacroiliac joint, is that we don't always get optimal results with the rhizotomy. And the reason is, or durable results. And the reason is because there are 4 major nerves that go to the joint. You know, you have S1, S2, S3, S4, and it's hard to hit all those nerves. It's a very large joint. So in my practice and experience, and I'm referred these patients by the pain management doctors. So many of them have failed the rhizotomies. But if someone is absolutely against surgery or doesn't want surgery, then I certainly tell them, go ahead and try the rhizotomy. There's no harm by that. It's minimally invasive, and go from there. I generally would rather fuse the joint than do a spinal cord stimulator. I'd rather fuse the joint than do a pain pump. I think that they don't work as well when you have a structural problem. And my bias is to fix the structural problem first and then save a stimulator or a pain pump for later. Does other people feel that way too, or do you have a different approach?
And in my practice specifically, I think that the injections have a very good result. I have done some rhizotomies and with moderate result.
Yes.
But I think that fusion can resolve some problems that the patient does not get better after these techniques. I think that we have some patients that will get benefit from it.
Yes, exactly. I've had patients where they've had stimulators in the past, and I fixed the SI joint, and they come back 6 months later and they say, "Can you take my stimulator out? I don't need it anymore." That's a very common thing. I only fuse one side at a time, and because if you look at the literature and the data, only about 20% of people need both sides fixed. So, and it takes a longer recovery, of course. You know, if you have, some people need a walker or crutches because it's a little tender to walk for the first few days. But again, I tend to be more of a sniper than a shotgun. I want to try to get in and out, short operation. Even in the beginning, when you first start doing this operation, it usually doesn't take more than 45 minutes to do it. And then as you get more confident and more, 5 to 10 cases, you'll be down to 20 minutes, 15, 20 minutes to do the procedure. It's not a steep learning curve, and it's a very gratifying operation. The patients are very thankful. They can get out of their recliner and go back to their bed afterward.
Perfect. We have actually a bunch of questions, so I will make one at a time. So the first, do you use neuromonitoring during your surgery?
That's a great question. There are some people who do neuromonitoring. I do not. If I am doing, sometimes I do a hybrid where I'm doing a 4-5 fusion with pedicle screws, for example. And if I'm there with it already, I will do a SI joint monitor. I'll put it there on the nerve, on the screw, to make sure, for example, the second screw is not up against the S1 nerve, or the top screw is not up against the L5 nerve. I've not had an issue with that. I had one time where I had to remove a screw because the lady had a very short aberrant ilium. And then she had a very short sacrum, and I was copying the other side. I had to come back and do the other side, and I was matching one screw to the other, and I had forgotten that the contralateral side, the new side that I was working on, was much shorter than the other side. So that was just a mental error on my part. And she came back and she couldn't dorsiflex without pain, and she was weak. And so I simply took her back to I did a CAT scan, confirmed that the screw was in the S1 foramen. I took her back and I took it out, and that was it. And the pain went away immediately. So yeah, if they're not significantly better at the 2-week follow-up visit, then I will get a CAT scan at that time. But again, it's uncommon to have anything like that. You want to stop about 1 centimeter before the foramen when you're putting them in. And there are measuring tools for that. You'll see as you go through and teach and proctor the course that it's very reproducible and easy to learn. and it's easy to learn for residents as well as attendings. You don't the mature surgeon and the residents both learn very quickly.
Perfect. And do you always use 3 screws, or and the size of the patient does make you change your technique if he's a bigger patient or smaller patient? How do you plan this?
Yeah, those are great questions. Again, I tend to look at the MRI in the beginning to look at the size. I also look at a CAT scan sometimes, especially usually you can find a CAT scan because they've had a prior fusion. I have a good friend in Atlanta. He's a trauma surgeon, and his name is John Keating. He goes by his first name is James, but he goes by John. He only does 2, every time 2, and he always gets a CAT scan because he wants to show the residents. He's in the residency program in Atlanta, and he's been doing this for 40 years. I do 3 because I was trained with 3 with the SI joint system when I first learned. But again, I don't think that there is one that's better than the other. There are many people just do 2. So I think it's whatever you feel comfortable with in your hands and how you want to do it. I don't think that there's an absolute yes on 3 or yes on 2.
What kind of grafts do you use? Do you have a special kind of graft for the surgery, or?
Well, as the screw turns, it pulls bone into it and wraps around the screw. So you don't have to add more bone to it in this system. You could certainly go posteriorly and augment it. You can open the joint posteriorly, visualize the joint, decorticate the joint if you wish to do that, and pack it with some bone, either from the crest or an allograft, a synthetic allograft. I've not found the need to do that. The success rate is so high at 94% that I've resisted that unless someone has failed a fusion. And I have a handful of cases. Some people like David Pauly out of Minnesota, who's one of the pioneers in this area, he sees a lot more non-unions or failed fusions than I do. Now, that being said, it's very difficult to tell if they've had a fusion or not. I mean, a non-union or not. It's really symptomatic. If they're still hurting after 6 months or 3 months, I will do another injection of the joint and see if it gives them relief. And then if that's the case, then I will augment it. But I usually give people at least 6 months time to heal, and maybe even up to a year, just like we do with spine surgery. So I think it's important to give it time, and the vast majority of these people will go on to fuse. There is postoperatively, some people will get piriformis syndrome, where the tightness of the buttock muscles, superior gluteal muscles, and that's treated usually with ultrasound, massage, physical therapy, and or trigger point injections. And I reassure them that that will go away.
And do you have any special protocol for the rehabilitation or post-op? How does you manage your post-op?
Yeah, that's a great question. I generally will let people go home the same day. Sometimes they go home the next morning if they live far away. We have people from hundreds of miles away. I let them shower the next day, take the bandage off and get it wet. I generally use staples or suture for the skin closure. I tell them to use moist hot towels in the morning to keep or hot shower. No baths for 10 days. I also will tell them through the day to use ice packs. Ice packs are good anti-inflammatory and reduce the swelling. And then I have them walking right away the same day or the next morning. If it's a little touchy to step, I reassure them that that goes away after a few days. They can get a cramp in the back of the thigh and the hamstring muscle. and I have them use a walker or crutches for a few days for extra support. But it's not always universal. That doesn't always happen. And so if they're not hurting, they'll tell you when they go to the bathroom that evening or after surgery. If it's not hurting, then they're instantly stable. They're very, very stable, and even a car wreck will not dislodge those screws.
Perfect. And Dr. Marcos asked, how does fixation contribute to relieve pain, and what criteria do you use during follow-up to confirm success? And also signs of failure and when need to reoperate. I think you partially has.
Yeah. Well, again, I'll take the first question, because I think there are three questions in that. The first thing you'll notice in recovery room is that they're not having radiating pain down the leg, or if they are, it's much less. The other thing that you can do is touch their foot, and many times people feel like there is tingling or numbness in the foot, in the second, third, and fourth toes. And they'll say, my foot feels like it's back with me. Many times people will say, I can't feel my foot, it feels alien to me, before surgery. And then after they say, my foot, I can feel my foot again. And then you know you've got the right diagnosis and the right treatment. It's instantaneous. I think the stabilization of the joint and deafferentation of the nerves going across the joint is what causes the relief, because they feel better even before they've taken their first step in the recovery room. And certainly you want to check for plantar flexion and dorsiflexion to make sure those are okay. The vast majority of the time they're fine. And then I let them get up and move right away. And I coach them with warm, hot compresses, wet compresses. Moist heat penetrates better than dry heat for the early morning when they first get out of bed. And then I use ice packs through the day to reduce inflammation, especially at nighttime. And I let them shower the next day so they can feel normal. I try not to make it too complicated.
Perfect. And Dr. Alexandre Pogaetti asked, are there different diameters screws or only one, and just the length varies?
Yes, so the standard screw is about 12 millimeters. There's also a 14 millimeter rescue screw. And then if, for example, you want to get a third screw in inferiorly at the bottom of the joint and you feel like you're running out of space, you can use a smaller one, like a 7 or 8 millimeter screw.
And Dr. Georgie Luis asks, have you ever used the lateral decubitus position for any reason?
I have not used the lateral decubitus position, but it's certainly a possibility. You can certainly try that. There's also other approaches, certainly the posterior approach, the lateral oblique approach. The screws can be used that way as well. Again, I leave that up to the surgeon to decide how they want to do it.
Also, Dr. Alex.
The third question, I had touched upon it before. They said, how do you know if you've got a failure?
Yes.
Right. Well, again, I follow them. I usually I see them at 2 weeks, and they may have some piriformis syndrome, as sorts of pain, maybe even a little radicular leg pain. I send them to therapy if that's the case. I give them SI joint exercises to strengthen their legs, and gait and balance exercises to strengthen their legs. Then I see them back at 6 weeks. And then I see them at 3 months. If they're still hurting at 3 months and they have not made significant strides, then I will do a CAT scan early rather than wait till 6 months. And then I will also, based on that CAT scan, I may do an injection at that time to see if perhaps one of the screws is a little posterior and it's not as giving as much support, or consider going back and augmenting the fusion with 2 levels, or getting an MRI scan of the lumbar spine to make sure that there hasn't been, say, a far lateral disc at 3-4 or or a paracentral disc at 2, 3 that's now causing the problem and mimicking in the SI joint.
Perfect.
Does
And
does
Dr.
that seem reasonable? Would you guys do the same thing? Yep.
Yes, I think it's something like that. And normally, as I told you, my experience during this with this kind of issue in sacroiliac joints, it's not that wide, and many of patients get better after injections. So I have a few patients that still have pain, and in this kind of patients, I'm now after the lecture, I'm thinking about them and thinking about how this screw could be an option. So I think that now that we have this tool in mind, we can think about it, think about fusion.
Yes, and the nice thing about it is once you start doing them, you'll realize what a great success it is for the people. They're very grateful to you. The hardest part in learning the technique is putting the first pin guide or the guide pin in first. Once you have that one in place, which is just inferior to the alar line and along the course of the sacral line, which bisects the joint, then you can use a parallel pin guide to put the second guide pin in. And you can even start with 2 and go from there. And it's a short operation, and it's a very safe operation. And then you could, or you put a third parallel pin guide down and they'll follow in stair step. And you can see that under x-ray. So, and you may want to start in the beginning with your x-ray tech before the patient is prepped and draped, and just get all 3 views while the patient's lying on the table. So you can see your lateral view first, your inlet view, and I have the x-ray tech make a note of where it is on the inlet view, because it may be 27 degrees, it may be 33 degrees. It's not always exactly 30, but it's going to be in that ballpark. And then you take it 190 degrees to the outlet view. And again, it'll be 30 degrees down the butt. It might be 27, it might be 33. Sometimes it's extreme, maybe it's 45. Maybe one's 15 and then when the other one's 45. But most of the time you'll find yourself right in that bandwidth. And then you can go from there.
Great. We have another question. Dr. Alexandre asked, is there a minimum distance between the screws so there won't be crack in the joint?
That's a great question. I have not seen cracking of the joint, but in general, we use a 14 to 16 millimeter parallel pin guide, so that there'll be 8 to 10 millimeters of bone between the two. So once you put your first guide pin in and you put your first screw, it's a cannulated screw. So the guide pin will then have, you can use the parallel pin guide, and that makes sure that you're not too close to the other one.
Great. And Dr. Ayrton asked, what is your experience with PRP in the sacroiliac joint?
Yes, that's a great question. I've looked at, I've done research on this area. I've done PRP. I've done stem cells, from the iliac crest, and also, and then bone fat or bone marrow, fatty stem cells too. Joe Parita, who's been a leader in the field, has uses the 3 together and mixes the PRP, the fat stem cells, and the bone marrow aspirate. It's about 50-50. We don't really know how many cells we need to have there or how much it's going to resolve. Sometimes it's expensive for some patients. I would say, majority of the patients are in the Medicare and on fixed incomes. But I think that's certainly a great option. Prolotherapy also, you can certainly try that. But my experience and what the literature says is about 50-50%, which is pretty good. It's not ideal. We don't know the exact number of stem cells to use or amount to do, but if a person wants to do that instead, I have no problem with that.
Pessoal, alguma outra questão? Alguém tem mais alguma pergunta? Quiser fazer diretamente também para o Dr. Adam, pode ficar à vontade. I have one last question, and in the tool of the screws, you have, you told about the pin guide. So you have a measure and that you can use, you have any kind of metric that you can use to, when you have the first screw put it in, you can guide the second and next one?
Yes, well, when you put in the second one, you've got you're going to look at the length of the joint. If it's a short joint, you'll probably use a 14. If it's a longer joint, you can use a 16. I generally stay with the 14s and work my way down. I don't want to get too inferior to the joint. The bone gets softer, and then there's the superior gluteal artery is down there. You don't want to get bleeding. If you do get bleeding, though, what I use is gel foam, and I wrap it up like a tampon, and then I put it in there. So it follows the same length as the tube. Because the steps are very simple. You have the pin guide, and then you have a dilator, and then you have a working channel tube. So it's just 3 parts. And then the screw goes in with the reamer, and it runs right in. Worst case scenario, if you do get bleeding, I've seen in 1,200 cases, I've seen 2 cases of a pseudoaneurysm of the superior gluteal artery. And the best treatment for that is interventional coils to coil the artery, which is very straightforward. Most interventional doctors can do that. But to avoid it in the first place, you want to don't go more than 2 centimeters from the bottom of the joint. And you should be very safe.
Great. Ayrton, eu acho que a gente pode encerrar.
Ok. Para finalizar, eu queria agradecer a presença de todos. Eu acho que a aula do Dr. Adam acrescentou bastante no nosso conhecimento, até os critérios que usa para fazer ou não as perguntas de diagnóstico foram bastante elucidativas. Dr. Adam, thank you for your class. My pleasure to give her in the night. Boa noite a todos. Muito obrigado à presença de todos. E para terminar, agradecer o Yusley pela oportunidade que ele deu para todos nós aprendermos um pouco da técnica, dos critérios e como utilizar o implante. Thank you, Dr. Adam. Bye-bye. Good night.
Thank you very much, gentlemen. Have a great evening.
Thank you, Dr. Adam.
Yes. Good night.
Good night. Bacana, hein, Ayrton?
Pessoal, gostei, viu? Gostei bastante. A aula, muito detalhezinho, aquelas perguntas de como sair no carro. Direto a gente pega esses pacientes que ficam sentados muito tempo e tem dor, e a gente não acha nada na ressonância, começar a ter outro olhar. E também o exame físico, né? A gente não usa muito essas... Eu uso o Faberi e eu uso o Gaesa de vez em quando. Os outros 3 não tenho muita prática no dia a dia. Vou começar a utilizar para ver se eu encontro alguma coisa com essas manobras aí. Achei bem legal a aula dele. Cara, você vê que o cara tem bastante prática e bastante simples, assim.
Pessoal, o bloqueio faz o diagnóstico. Olha, os que eu vi, fiquei em dúvida aí, eu praticamente não faço ressonância nem nada, eu já vou direto para o bloqueio. Se o Faberi é positivo ali, como se disse, eu indico o bloqueio. Se não passar, pode escrever que não é sacroilíaca.
O padrão ouro realmente é injeção, né? É fazer a infiltração da sacroilíaca.
E o Ferraboni falou um negócio interessante, que aí no dia a dia a gente não usa muito. Ele usa ropivacaína com triancil, né? Eu uso muito lidocaína com dexa. Começa a melhorar a potência do bloqueio, acho que pode ajudar até melhorar o diagnóstico.
Eu escutei no pessoal de Fênix, Foi eles que passaram uma vez essa dica, porque como ele mesmo falou, a sacroilíaca ela é inervada por
4 nervos, né?
e vai muito pouco ml dentro da articulação. A articulação é muito estreita. Então, se você consegue potencializar, tu melhora o teu resultado terapêutico.
Muito bom. Eu achei que ele, cara, tem experiência, foi bastante claro, né? Explicou, o que eu acho legal, por exemplo, colocou as complicações. Mostrou que não isento de complicação e não é para tudo, né? Que é o que realmente a gente queria aqui. Quando você pede alguém para dar uma aula, não é para ele mostrar a 8ª maravilha do mundo, é para ele mostrar mais um dispositivo, uma técnica e os prós e os contras de usar, né? Eu achei que ele foi bem claro nisso e eu gostei da aula. Acho que vai trazer conhecimento a mais para o meu dia a dia. Boa noite a todos. Obrigado, Ferraboni, por você ter entrado aí. Prazer ter todo mundo aqui. Tchau, tchau.
Obrigado, Ayrton. Tchau, pessoal.
Obrigado, pessoal. Muito obrigado. Uma boa noite.